Hi everyone, I'm Dr. Armanda Nangmo from Cameroon and I'm here to present today my abstract entitled this. HIV and AIDS still remain a problem in the world and mainly in Africa where we still see adolescents living with HIV dying from AIDS-related causes. And most importantly, as adolescents require a transitioning from pediatric to adult ARV management, we are therefore in need of novel approaches to maintain suppressed viral load for adolescents that will favor transition and in their transition and improve ART program management. So the main objective of this study was to assess therapeutic response, HIV-1 drug resistance, and genetic variability among adolescents receiving first and second-line antiretroviral drugs in Cameroon. So to attain our objectives, we carried out a multi-center cross-sectional study during 4 months. We did a convenient consecutive sampling of perinatally HIV-infected adolescents on heart. Our minimal sample size was 250. We had 6 study sites, 2 in the urban and 4 in the rural zones of the central region of Cameroon. In the study sites, we enrolled patients after consenting procedures were applied. We consulted their hospital records as well as their pharmacy attendance sheets. We clinically assessed them and we did phlebotomies. The samples were shipped to the Chantabia International Reference Center for HIV Prevention and Management, where laboratory analysis were done. We did CD4 counts, viral load, and genotypic resistant testing for those whose viral load was above 1,000 copies per milliliters. We can see that the gender distribution was similar, indicating on one hand that HIV in adolescents concerns both boys and girls, and on the other hand that our finding can be translated to the entire population of adolescents living with HIV. The median age of the population was different, but not statistically significant. This implies that there's a great number of children born with HIV who are gradually going into adolescence. And concerning clinical failure, our clinical failure rate was high, different from what was obtained in India in 2016 by Boytiger and al. They use only stage 4 clinical disease for clinical failure, whereas we use stage 3 and stage 4 clinical disease. Concerning virologic response on ART, it was high globally and per setting. This high virologic failure rate in the urban site was generally higher than what was observed in previous reports some years backwards by Focam and al. And also, this high rates of virologic failure clearly shows that adolescents on antiretrovirals might not be responding favorably to the current treatment regimen. Concerning HIV drug resistance, it was generally high and mainly associated to NNRTIs, and there's a great rate of dual-class HIV drug resistance. So we can conclude that adolescents living with HIV usually appear clinically asymptomatic, and the virologic failure was similarly high, associated with HIV drug resistance mainly to NNRTI-based regimens, and consistent with high rates of dual-class HIV drug resistance. Thus, NNRTI sparing regimens might be convenient when transitioning adolescents to adult ART regimen. Therefore, there is an urgent need to implement the United Nations AIDS recommendation on replacing NNRTIs with molecules of higher genetic barrier like dolutegravir for proper transition of adolescents living with HIV into adult care. Thank you.